Bore da, a chroeso i bob un ohonoch chi i gyfarfod y bore yma, sef cyfarfod Bwrdd Iechyd Addysgu Powys. It's a pleasure to be able to welcome each and every one of you to this meeting of Powys Teaching Health Board. I should start by saying that we're starting a few minutes later than scheduled. Apologies for that. And the reason is that we've encountered one or two technical difficulties. This is a virtual meeting, and what we're experiencing is that the camera feeds of some of our board colleagues are not working. And so when you look at the screen, it will probably be that you can see some people, but other people just have a blank box with their names on them. Apologies for that. We will proceed with the meeting. And when we break for a comfort break during the morning, then colleagues will try to sort it out, and hopefully we will come back and things will be working fully. So ymddiheuriadau am problemau technegol, ond mi newn ni yn gore I ddatrys pethau cyn gynted â phosib. And so, as you can see, we are holding our meeting virtually. It's being live streamed through the Health Board's website, and a very warm welcome to those who are viewing our meeting this morning. And as always, a recording of our meeting will be also available online after today for anyone to access who can't be with us today. Cael cwpr y dwi a fi ydi cadeirydd y Bwrdd Iechyd, ac mewn munud fe welwch chi ar y sgrin restr o enwau yr aelodau'r bwrdd a rai fydd yn cyfrannu at ein trafodaethau heddiw. In a moment, you'll see the list. There'll be a slide on the screen that shows you the list of board members and of those that will contribute to our meeting today, as well as those colleagues that can't be with us and whose apologies for absence we have received. Ein pwrpas ni fel bwrdd ydy I fod corff llywodraethol sefydliad. Mae gen ni aelodau annibynnol, a mae gen ni hefyd aelodau gweithredol, a chyda'n gilydd, dyn ni yn cario allan ein busnes fel corff undebol, fel bwrdd undebol. We are a unitary board made up of both executive members and independent members, and we bring that mix of skills and complementary responsibilities to bear as we fulfill our responsibilities as the governing body for the organisation. Ond wrth gwrs yn bennaf, ein pwrpas ni ac ein cyfrifoldeb ni ydy gosod cyfeiriad strategol y sefydliad, gosod archwaith risg, wrth I ni ystyried ein hamcanion strategol, monitro perfformiad y sefydliad yn erbyn yr amcanion strategol hyn, ac hefyd yn bwysig iawn I osod ac I ddatblygu diwylliant iach a diwylliant positif o fewn y sefydliad. We have a number of responsibilities, but mainly they are to set the strategic direction for the organisation, to set the risk appetite as we deliver those strategic aims, to monitor performance against that delivery, and very importantly, to shape and to demonstrate and embed the values and the culture of our organisation. A very key item on our agenda today is item 4.2, which is the annual plan update and the temporary service changes. And it's probably worth explaining at this point that that item follows a decision that we as a board took in an in-committee meeting back in May to implement these temporary changes. And when we come to that agenda item in our meeting, as a board, we will hear more about how those changes and how the process, as it were, is being implemented, and indeed how effectively that is being carried forward. And a very important part of that is about receiving assurance in relation to the public engagement, which will start imminently in association with those temporary changes. And finally, before we get to our agenda proper, just to explain that we have quite recently started to operate a consent agenda, and essentially these are items that are not controversial and are quite routine, and as a board we agree that they don't need discussion in our meeting today. Of course, it's always possible for any board member to request that something on the consent agenda be moved from that and actually become a substantive agenda item for consideration and discussion. That hasn't happened today, and so the expectation is that those items under the consent agenda will be approved en bloc. We will take some breaks, as I intimated earlier, as we move through the meeting. But for now, we turn to the agenda proper and to item 1.2. A'r peth cyntaf dwi'n gofyn ydy I bobl ddatgan unrhyw diddordeb mewn unrhyw eitem ar yr agenda. Are there any declarations of interest from any member in relation to any item on the agenda today? Would you please indicate if so? No, there aren't. So we move on to item 1.3, which is the board action log. This has just been added to our board pack, and so our papers, I should have said earlier, our papers are available on our website for everyone to read and to follow our agenda. But this particular paper was only added this morning, so you may well not have had a chance to see it. However, there are only 2 items on it, and I'm going to ask Helen, our Director of Corporate Governance, and then Kate Wright, our Medical Director, just to address those 2 items. We'll go to you first, Helen, please.
Diolch ar bore da, Helen Bushell, Director of Corporate Governance. There are just 2 actions on the board action log, none recommended for closure. The first one is a transfer of action. It relates to reducing waste and efficiencies from business process improvement. That action has been transferred to our Delivery and Performance Committee, and that has been added to the work programme for that committee during the course of the year. The second one then was an action from the last board meeting, and it was in relation to clarification regarding the length of retention of patient records. And Kate, if I could just ask you to update on that, please.
Yeah, thank you, Helen. Good morning, everybody. Kate Wright, Medical Director. So this was, I think the question was around there had been a rule about retention for a certain list of long-term conditions which had been new and needed clarification. Clarification has been sought, and it is confirmed that that list does not apply to secondary care, and therefore the programme of notes management and records management that we have has been able to continue. So I hope that answers the question.
Thank you, Kate. Would anyone like to come in at this stage with any comment or question in relation to those actions? No? Thank you for that. In which case, we go to item 1.4, and a very important part of our agenda where we listen. This is just one of the ways in which we listen to patients, to people, to staff, in order to, if you like, make things real. We receive a lot of information, a lot of data and so on as board members, but it's really important that we listen to people who carry out the business of the board day in, day out, and to those who receive our services. And so our Marie Davis, the Executive Director of the Assistant Director of Nursing Quality, Women and Family Health, is going to introduce the patient experience story. Thank you, Marie.
Thank you, and good morning, Bardar. Marie Davis, Deputy Director of Nursing. It's my pleasure today to introduce a story from Kath, and Kath is going to tell us about her experience of our midwifery service and the use of our birth centres. So thank you, Liz.
Hi, I'm Catherine, and I was looked after by a team of Powys midwives during the births of my 3 children from 2019 to 2022. I live in a rural area on the outskirts of Newtown, and I've been asked to share my experiences of being looked after by the Glyndŵr team of midwives. I think it's fair to say that, like most first-time expectant mothers, when I went for my first few appointments with my first baby, I wasn't quite sure what to expect with pregnancy or birth. And I think I'm the type of person that I do like to control what I can, and what I can't control, I try and go with, and just go with it the best I can. So when my midwife James asked me where I'd like to have my first baby, my initial thought was that I definitely wanted to have it in a big hospital, because that's where I'd be safest with worst case scenarios. But after doing some research of my own and doing an online hypnobirthing course, I realised that it could be an option for me to go local and to have my baby at a midwife-led unit. So that's what led me on to, with my first and second baby, I said I'd start at home, see how I felt, and go down to my local midwife-led unit, and then I could always go on to hospital then afterwards if I needed to. So I think it's important to say here as well that during the first pregnancy, that the Glyndŵr team of midwives were part of a project on continuity of care, where it meant that the relationship between the patient and the midwife was heightened. And I'd say that I felt very connected with my midwife, which probably then gave me the confidence to want to birth in my local midwife-led unit. So with my first, in the end, I did decide that I would start at home, see how I felt, go down to my local midwife-led unit, and then if we needed to, go on to a big hospital. So a big hospital for me is about 1 hour and 20 away. But if I wanted my children to be born in Wales, which I did if I could, then my nearest big Welsh hospital is 1 hour and a half away. So having that midwife-led unit 20 minutes from me, but on my way to a big hospital, was a big thing for me, I felt. I also felt that with my second, because I'd already had one baby in my local midwife-led unit, and I was really happy with how that birth had gone, I wanted to try and achieve the same birth outcome and experience as I could. So again, I decided to start at home, go down to my local midwife-led unit in Newtown, and hopefully have them there, which I did, and I was fortunate to do that. And I was home within probably 2 to 3 hours after having them, which was really nice, especially with having one already at home. So after having 2 babies in my local midwife-led unit, I felt that I had the confidence to maybe explore a home birth. My body had done it twice already, and I quite liked the thought of being at home, relaxed and comfortable in my own home. I also realised after my first and second baby that the midwives will bring everything out to a home birth that they would have in a midwife-led unit anyway. Even though I think for my first and second birth, I felt a lot safer going to my local midwife-led unit, whereas third time, I sort of knew what to expect and I knew my body more. So I felt more comfortable to be able to have my baby at home. And then with my third baby, I was hoping to have them at home. So because I'd had the first 2 in a birthing pool in the local midwife-led unit, it was very important to me to try and be in a birthing pool again. So I did hire a birthing pool to come to home, and we had that set up at home. And I thought, well, I could start at home, see how I go again, try and have them at home. But if I couldn't or didn't feel right, then I could obviously go on then. And I've got the option to go on to the local midwife-led unit or onto a bigger hospital. And fortunately that I started at home, and I was really fortunate to have my third baby at home on Christmas morning. There's more than one way to go home. So I think that birth is such a huge life event for women, and if we can empower them to make their own choices, to have confidence, to have their babies wherever they want to, if that's at home, in a local midwife-led unit or in a big hospital, as long as midwives are equipped that they can support them, I feel like that's what we should be encouraging. It's hard to try and describe the level of trust that was built up between me and my midwife, James. James was my midwife, as I said before, throughout the entire 3 pregnancies, and he wasn't just there during the pregnancies, but he was also there during the births of all 3 of my children, which I'm so fortunate to have had him for all 3, but also afterwards he was there in sort of aftercare. And that level of trust that you build up and the relationship you build with your midwife through the coming from that project of continuity of care, I think is so special, given the fact it is such a big life event for women. So for me personally, because I already had 1 or 2 children at home, to go in and have another baby, I didn't want to be travelling a long distance, going to a big hospital and potentially staying there for a night or 2. So having that midwife-led unit local meant that I could go down, feel safe there, but also come back relatively quickly to my other children and feel comfortable doing that. So thinking back to what I was like going into my first pregnancy appointments when James was asking me where did I want to have my first baby, and as I said to you, my initial thoughts was I want to go to a big hospital. I feel like I did a massive U-turn on that to actually then go on to have my first 2 children in my local midwife-led unit, and then even have the confidence to have my 3rd baby at home. So I never would have planned to have a baby at home, but obviously from having the confidence, from having 2 children previously, knowing my midwives, having that local midwife-led unit available to me as a midway point, if I wanted to, I feel like that definitely empowered me to be able to have my baby at home. I think that having choice is such a big thing, and especially for us living in rural areas, to have the option of a local midwife-led unit and the option of a bigger hospital which is further away if we need it, definitely makes us feel safer as we approach giving birth. Definitely the relationships that I built with our midwives and the trust, especially between me and James, my midwife, was the reason I think that I managed to have such positive experiences during all 3 of my births, and I feel eternally grateful to James for that.
Can I just check that I'm not quite sure whether that video feed ended prematurely or whether whether that was the end and we carry on. Could somebody?
That was the end. That was the end, Carl. It ended as planned.
Okay, lovely. Thank you very much. Marie, I just wondered whether you had any comments or observations you wanted to add before we move to our next staff experience story.
Just to add to Kath's experience, really, we do try and work with our women quite closely, trying to make it a really positive experience for them. And where possible, there are risks that sometimes means that women need to birth elsewhere. But where that's possible, we do try and keep that sort of community service and allow them to deliver within Powys.
Thank you very much. Now, we don't discuss the patient and staff experience stories at board meetings. However, we do have other ways of considering what we learn from those, and indeed what we learn from other ways of engaging with staff and service users and the population more widely. But as I say, a big thank you for that and for all that we learn from it. So we move now to the staff experience story, and in the absence of our Executive Director for People and Culture, Claire Madsen, our Executive Director for Therapies, is going to introduce this item. Thank you, Claire.
Thank you, Chair. Morning to everybody. So I'd like to introduce Jo Allen for this section of the board agenda. Jo is our clinical lead for respiratory care in Powys, and she's going to explain her journey coming to work in Powys and also the current work that she's doing. So welcome, Jo.
Thank you, Claire. Good morning, everyone. Borodar. There's my first slide. So my name is Joanne Allen, Jo. I'm the Respiratory Clinical Lead for Powys Teaching Health Board, and I'm a respiratory specialist nurse. I qualified in Birmingham in 1995 and started my career on a respiratory ward. Since qualifying, I've worked for a range of different trusts and organisations in and out of respiratory specialities in England and in Wales. I've worked solely for respiratory for the last 15 years, being lucky enough to have worked in departments across primary, secondary and community care. I've worked for Powys Teaching Health Board for the last 8 years. Until autumn 2021, I led the Community Respiratory and Oxygen Service for North East Powys. Since autumn 2021, I've been in my current role, this one, Respiratory Clinical Lead, which was a new role for the Health Board, leading the exciting transformation of our respiratory services. During this transformation, our focus has been on developing a Powys-wide multidisciplinary team that provides respiratory assessment, support and education. We also provide the home oxygen assessment service. Our service supports individuals with long-term respiratory conditions to live well and confidently manage their symptoms, to remain active, reduce the frequency of exacerbations or flare-ups, and avoid hospital admission. Along with this, our transformation project has been crucial in bringing patient contacts and appointments back into Powys, rather than patients having to travel out of county for assessment and care. This has been achieved through a variety of initiatives, including a home oxygen project, establishing our physiology service to repatriate some respiratory diagnostics to Powys, and standardising our service across our health board. Our physiology service is the only one in Wales that has a hub and spoke model for spirometry clinics. We offer diagnostic spirometry in outpatient departments across Powys community hospitals. We've also recruited more staff, including more therapists, and developing the role of respiratory healthcare support worker. Thank you. As lead clinician, I've also focused on strengthening our links with primary care. We've started things like a monthly virtual drop-in session for all primary care staff, and every 6 months we have a respiratory education update day for any staff across primary and community care. More important, well, from a patient point of view, you'll see the photograph on the bottom right. We now have a rolling programme of virtual pulmonary rehabilitation courses, which is led by our therapy staff. And the QALY triangle on that slide demonstrates the value and importance of pulmonary rehabilitation. It is a 6-week evidence-based intervention for people with long-term respiratory conditions. We are also supported by other departments who help patients to access this. For example, in using technology, we can arrange the loan of tablets for the duration of a course and support to use them. We've also run our first face-to-face pulmonary rehabilitation courses since the pandemic for those who do not have an email address. Following our initial oxygen project, all of our oxygen prescriptions are followed up in line with the guidelines and risk assessments to ensure patients are safe and adequately prescribed oxygen are up to date. I represent our service at all Wales meetings, for example, the oxygen meetings, the respiratory network and the cross-party lung health group. Thank you. Our multidisciplinary team includes physiotherapists, occupational therapists, healthcare support workers, physiologists and admin staff working together. This is one of the things that I enjoy most about working in a multidisciplinary service, different disciplines supporting our caseload, contributing distinctly different aspects to our service and each other's professional development. I aim that this contributes to retention of staff in our service in the long term, and we prove that we can embed a specialist service in a community patch and proving that you can live well with long-term respiratory conditions. I've always enjoyed working for Powys Teaching Health Board. This role is particularly exciting and innovative. However, it does come with its challenges. For example, delivering our specialist service across a large rural area and the practical issues that this imposes. Without a district general hospital, we manage communication with several other health organisations and departments across all of our borders. English and Welsh. This is why it's so important that we deliver as much as is possible in Powys. Recruitment to our service has been difficult, especially to our clinical roles. With support from the Health Board, we've planned roles slightly differently. We plan development roles where we develop and grow staff within our speciality, and hope to make a more robust workforce for the future. Despite these challenges, Powys Teaching Health Board continues to be a forward-thinking organisation. I feel that my team and I are listened to and valued, and the support and development opportunities that have been shown for me in my career here have been really positive. So far, thank you very much.
Joanne, thank you. And so once again, I'll go back to Claire and ask Claire if you have any observations you'd like to make.
Thank you, Chair. Yeah, I'd just like to say I've been really fortunate to work with Joe and the team for some years developing this respiratory service, and I've been really proud to watch the team grow, and particularly the introduction of new professionals and skills into Powys, and we've been able to offer services much closer to home. So I just want to say thank you, because under Joe's leadership we've developed a really truly multidisciplinary team and offering very excellent services to our patients. So thank you, Joe.
Yeah, thank you. And so on behalf of us all, a really big thank you to Catherine for sharing her experience of the maternity services, and to Joe for her experience as a staff colleague, and for her leadership, as Claire has just said, and particularly important to learn about the challenges as well as what's going well and what's being achieved. And so again, that certainly has been heard, and we will take that into our considerations and our conversations. But for now, thank you very much. So we turn to item 1.5 on our agenda. We have this now as a standing item on our agenda, where we welcome questions to us in our public board meetings from our population, from the people that receive our services. I think I'm right in saying, Helen, that we haven't received any questions to the board for today. Is that right?
Yes, that's right, Carl. You've received some correspondence with regards to later items, but no broad questions to the board. Thank you.
Yeah, and I'll pick that up later. So thank you for that. In which case, we move swiftly on to item 1.6 and to the update reports. Initially, my chair's report. I'll take the report as read. I don't have any additional comments, but I'm happy to enter into conversation or take any questions about any aspect of the report. Does anyone want to contribute at this stage? No? Thank you. In which case we move to our Vice Chair's report and to Kirsty. Any additional comments, Kirsty?
Bore da, pawb. Good morning, everybody. No, Carl, no additional comments from me, but very happy to answer any queries or questions.
Thank you. Is there anything for Kirsty? No. So we move finally under this agenda item to our Chief Executive's report and to Hayley. Thank you, Hayley.
Yeah, bore da. Thank you, Carl. Just take the report as read. I think there was one item I felt I should mention which isn't in the report, but clearly the UK COVID-19 Public Inquiry Module 1 report is now available, which covers the preparedness. So I just wanted the board to be aware we've received this report. We will be reviewing this and taking learning and the recommendations forward, both in the context of as a health board, but also as NHS Wales, working with government to look at how we can take the learning and implement the recommendations. Other than that, in the report, just to remind colleagues that we have recently been updated on our escalation position, and we continue to be in enhanced monitoring for planning and finance, and in routine monitoring for all other areas. And also in the report, I know the board in public had considered in previous meetings the important decisions relating to the EMITHS decision. So again, just for information, that we have received a letter before action on the 5th of July in relation to a potential digital review regarding the EMITHS service review. Other than that, I'm happy to take any questions. Thank you.
Thank you, Hayley. Does anyone want to ask a question or okay? Ronnie Alexander, please.
Thank you very much, Chair. Ronnie Alexander, independent member. Hayley, perhaps I could just pick up a number of points very briefly, please. On the, and by the way, your report is, as always, very helpful. Thank you. On the EM RTS Wales Air Ambulance and the work of the Task and Finish group, which is supposed to be completed in October, can I just ask, are we reasonably certain that that work will in fact be completed on time? And then in relation to the Vaccine Saves Lives Award, which is commendable, I just wanted to check where we are in relation to MMR and also the COVID spring vaccination campaign. Are we satisfied with progress on both of those? And finally, note the very important work that Heather has been doing on the diagnosis of dementia. And just say, of course, the diagnosis is the first important step for people in terms of their aftercare provision. And for some of them, that journey will be rapid, and for some of them, that journey will be slow. So I'm just seeking assurance that the care arrangements which are necessary to support that diagnosis are effectively in place. Thank you.
Thank you. Really good questions, Ronnie, as ever. I'll answer the first one, but just to warn Mez and Marie, I'll ask you to come in on the questions regarding vaccination, Mez, and Marie with regard to dementias. Marie has been leading the dementia steering group, if that's okay. In relation to the Task and Finish group that's been established, Pete attended the Joint Commissioning Committee on my behalf last week, but we have been given assurance that the timetable set with regard to the JCC receiving the work from the Task and Finish group continues to be planned for October, as per the timetable that we shared in the board when we considered the initial recommendations. I think that there's been 2 meetings of the Task and Finish group to date. I'm really pleased that we've got Kate Wright, our medical director, and Stephen Powell, as well as our director of performance commissioning, involved in both the Task and Finish and the technical modelling group that sits within that. There is a lot of work to do, Ronnie, but we have been given assurance by the JCC, in the JCC, that that work is on target to come back in October. So if I could ask Mez to answer the points around vaccination, thanks.
Yeah, diolch Hayley. Morning. Thank you, Ronnie. So, yeah, in terms of MMR, we activated a working group consisting of partners in local authority and Public Health Wales in January to look at and review our MMR uptake rates, but also drive them up in light of the outbreaks in Midlands, London, and subsequently in Gwent as well. So pleased really that there's been a really good multi-agency response, equally working with schools as well. So we have been doing catch-ups. We've been working with primary schools, secondary schools, and also writing to parents and guardians of children we'd identified who may have missed the MMR, or whether we didn't have up-to-date documentation for them. So that response has been really good, and what we're aiming for is to have uptake of at least 90% in our school-aged children to prevent sort of outbreaks. Equally as well, we've been doing work with healthcare staff as well to encourage staff who may have previously not been eligible for MMR to come forward, and we also open an open door walk-in at our centres in Brontlis and Newtown as well, and that offer continues to the public as well. The message is it's never too late, and if you're not sure whether your child is up to date, or young people, and also with people going to college and universities, equally welcome to walk into the centres. In terms of COVID Spring programme, so that campaign is now complete. Uptake, we have got the highest uptake for health boards at Wales is around 60%, which is lower than what it was initially in the phase of the pandemic. We did continue to do outreach clinics, sort of centres, and we're currently now in the planning stages for winter respiratory programme as well. Yeah.
Thank you. Diolch Mered. Ronnie, are you content, or would you like to respond?
Thank you. I'm content thus far. I was hoping for some comment on support around dementia diagnosis.
Yeah, could I ask Marie to come in? Thank you.
Yes, thank you. Thanks, Hayley. Thanks, Ronnie. This is a really important part of work for Powys. As Hayley said, I chair the Regional Dementia Steering Group, and Heather, it's been great to see Heather recognised for the work she's doing with dementia. She is the clinical lead for a Dementia Standards programme, which is a national programme, and we're just coming to the end of that, and then we'll go into a new approach defined by the national team. One of the great successes is the improvement of diagnosis, and we'll carry on doing that work because we know it's really important that we actually identify people quite early. There is a lot of support and help out there and information that can really help families cope with it can be a very debilitating illness, but you can live for many years quite successfully living with dementia. The steering group is made up of statutory bodies, third sector partners, and also users, so people living with dementia, and we've got quite an active group in that space. In terms of the diagnosis, not only we are on a programme to improve that diagnosis, and that includes how we capture information, but also about reaching out to the community and engaging with the community so people step forward as well. So if you do have some worrying signs, then please do see your GP. There is a lot of help out there. We are also about to start some work with some investment, hopefully from the Welsh Government, where we improve the navigation. So once people are coming forward to be diagnosed, there is somebody who can steer them through the appropriate services and the appropriate support. And we're co-producing that with our partners in Powys. So we look forward for that developing over the next year.
Thank you. Carl, just to say, I think the dementia dimension is particularly important against the fact that we have an ageing population. Thank you very much.
Thank you, Ronnie. I can't see anyone else wanting to contribute in response to the Chief Executive's report. So we thank Hayley for the report. Thanks for the discussion. And we move to item 1.7 on our agenda, a very important item, as I always explain in our meetings. A lot of work goes on as a board outside of our public board meetings, and this work is done by our subcommittees, who often do the detailed work in terms of scrutiny, consideration and challenge. And so we're going to go through each of our subcommittees now to receive their report, but also to give the chair of that committee an opportunity to offer us the assurance that we need. So we turn firstly to the chair of our Audit, Risk and Assurance Committee and to Robert. Diolch, Robert.
Thank you, Chair. Robert Lewis, independent member. There are two matters I'd like to highlight from our 9th of July audit meeting. First of all, the annual report and accounts, which include the accountability and performance report. These had already been considered in the previous meeting as well, but they were subsequently considered, agreed, and signed off by the Health Board itself in a meeting on the 11th of July. And the second is internal audit. Despite best intentions, internal audit reports come through in clumps in January and March, and in keeping with our determination to continually review not only what we receive, but also how we consider it and how we work, I will be working with the committee and the board secretary to look at ways we can prioritise our review of internal audits according to outcome, with any audits receiving lower ratings and getting a higher degree of scrutiny. Thank you, Chair.
Thank you, Robert. Just to be clear, that again, that is that source of assurance, Robert, but not necessarily escalated matters for us as a board.
Yes.
Okay, thank you. Does anyone want to contribute and or ask or question, make a comment in relation to the ARAC report? No, in which case we go back to Hayley, our Chief Executive, who chairs the Executive Committee. Thank you, Hayley.
Carl, I can see Hayley just having a bit of difficulty coming off mute there. Adrian, are you able to unmute from the central position?
Okay, whilst we're trying to sort that out, we'll move on to our Delivery and Performance Committee and to Ronnie. Thank you, Ronnie.
Thank you, Chair. Just to say that on behalf of this committee, I have tabled a 10-page report, but the first 5 pages refer to our meeting on the 7th of May, and I've reported verbally on that at our last board meeting and undertook to produce a substantive report for this board meeting, and that is at pages 1 to 5. Then at page 7 to 10, this deals with the matters which were discussed on the 27th of June. I'm taking the report as read. I will particularly just reference, if I may, the financial challenge, particularly in relation to pay and agency costs, and I know that Pete will reflect further on that during this meeting. On a more positive note, I will say that at page 7, in relation to primary care and out of hours, we received a very positive report on the way that ShopDoc was working and the fact that there was little onward referral to other services, in particular less than 2% to 999. So on that basis, I will stop, but I'm happy to take any observations or questions. Thank you.
Thank you, Ronnie. So I'll pause and invite questions or contributions in response to the Delivery and Performance Committee report. There aren't any, and therefore we'll go then back to Robert, who also chairs the Planning, Partnership and Public Health Committee. Thank you, Robert.
Thank you. Well, the summary in front of you is very comprehensive. I have nothing to add to that myself, but I would like to defer to Ian Phillips, who I think stood in for me for that meeting. Ian, if you've got any observations.
No further observations apart from to say that due to the timing of meetings, I did verbally update the board and colleagues at our last meeting, but if there are any further questions, I'm happy to give that a go.
Thank you. Again, please do indicate if you'd like to respond to this report. No, therefore we come to our Charitable Funds Committee, the Powys Charity Committee that I chair. I will take the report as read. The only item I would want to say is to acknowledge our thanks to Abe Sampson, who has recently left us and was our Powys charity manager, and whose contribution during his tenure of that post saw the development and the strengthening of the charity, both strategically and operationally, make some quite significant steps. And so we are certainly very grateful to Abe, and we wish him well in his new role and his new responsibilities. And also thank you to Martin, who has stepped in as an interim arrangement, and again is already doing sterling work for that important charity. So, with those are my only additional comments. Would anyone like to ask a question or make a contribution in response to the Charitable Funds Committee report? No. In which case we move to Workforce and Culture Committee and to Ian. Thank you, Ian.
Bore da, thank you. Nothing to add. Particularly happy to answer any questions, but I did just want to make a couple of comments, if I may, Carl, with the work of the committee, particularly in the light of discussions we're going to have later on in the agenda. I think I guess my summary for folks that are reading the report is we've recognised the fact that it's difficult to get and retain staff for many years in many areas. And our reliance in other committees on bank and agency. We've got an ageing workforce and an ageing population, and I think the report demonstrates that we're working on these areas, and we've had some success. I'm particularly pleased with the Aspiring Nurses programme, a lot of proactive work. But I think the point for me is there's such a lot more to do, and we can't do this fast enough. So I think for me, this report highlights particularly the need for us to have our focus on that sustainable future that we're going to be speaking on later on in the agenda, and how we get there to that sustainable future with urgency for the sake of quality, safety, and the staff undertaking a tough job. Those are the comments that I would like to add, which hopefully informs our discussion later on. Thank you.
Yeah. Thank you, Ian, which also, of course, highlights the importance of all of our committees, but as you quite rightly say, and therefore the importance of the assurance that comes via yourself from your committee, and so that is noted and appreciated. Does anyone want to respond to the Workforce and Culture Committee report? No, so I'm going to try to go back, therefore, to the Executive Committee report, hoping that Hayley's been able to unmute herself. Hayley.
Yes, thank you, and apologies to you all for that technical hitch. I logged out and came back in. So this report is in a new format for today's meeting. It covers the breadth of the Executive Committee decisions over 6 meetings that were held during May and June. I think it's, I welcome your comments, but I think the improvement around this is in particular for you to be able to see a clear line of sight between the items that we discuss and for what reasons in our committee, and then how it feeds into the relevant committee and board. I'm not planning to cover the detail of the report. I'll take the report as read and happy to answer any questions. Thank you.
Thank you, Hayley. Would anyone like to contribute, ask a question, respond to the Executive Committee report? No, okay, thank you for that. In which case, or before we leave this item, can we just go back to the cover paper, please, and the list of escalated matters? And I wondered, Helen, whether you might like to just come in. There are a few of those escalated matters, perhaps particularly from our Patient Experience and Quality Safety Committee, that seem to have been there for a little while. I just wondered whether we might reflect how those escalating matters either get de-escalated, or, if you like, what we do with them as a board when they seem to be there for some time.
Yeah, thanks, Carl. I think it's a really helpful observation. And I think probably going forward, we need to be a little clearer about what we mean by escalated, and i.e. that does that require some board action, or actually is it for board awareness and information? So I think that's an important point for us to reflect on. All of these committees, including our patient experience and quality committee, keep a very keen and consistent eye on the matters that are that have been escalated or informed to board. But I think with committee chairs agreement, what we'll do in the next quarter, at least cycle between now and sort of September, October, we will review these again and perhaps provide a different update to the board in September about whether these items continue to be in need of escalation, or whether they've actually now taken on a different status. So perhaps with Curtis' agreement, we'll start that at PECS next week, and we'll report back to the board in September, Carl. But in terms of the items on the paper, I have nothing else to add in addition to the updates that are there. Thank you.
Thank you. Kirsty, please.
Thank you, Helen and Carl. As colleagues will have seen, there is no report from PECS on this board agenda today. That's because the PECS committee will meet on Tuesday. So we will take into consideration the observations you've just made, Carl, to clarify the nature of the items that have been escalated. As Helen says, sometimes the committee hears things that we feel that all board members need to be aware of. That's not because we expect the board to do anything about it, but we do not want to we don't want any of our colleagues to be unsighted on any issues or any concerns that the committee has identified. In other areas, there will be a formal escalation process around a particular service. Colleagues will all be aware that our mental health services are subject to that escalation process at present. The committee keeps a very close eye on progress on that and will report to board accordingly around progress. I just want to assure everybody that all items are on the log related to PECS will be continually monitored, and there will be a full briefing from the PECS committee following our meeting on Tuesday at the next board.
Really helpful, Kirsty. Thank you very much. Jen, you had your hand up. Do you still want to come in?
Yes, I do. Thank you. I was having a bit problems in sort of keeping it raised. I beg your pardon, but thank you, Jennifer Owen Adams, independent member. Helen, probably one for you actually. Something that you've already started, which is looking at joining together the chairs of the joint committees of the committees that feed into this board, and doing that joined up thinking, which we've talked about before. Just wanted to know how that work is going, and are there any key themes which are emerging from the meetings that all the committee chairs are having?
Thanks, Jen. Carl, would you like me to respond, or
no, please do. I can add something if needs be, but please do, Helen.
Yeah, thanks, Jen. And that's a really helpful question, actually. It just makes me reflect that there probably is something important about how we share that information on a more regular basis with the whole board, actually. So we'll take an action and maybe just consider how we do that. Carl and I were having a similar conversation about board development yesterday, actually, so we can maybe put it in that context. But the committee chairs forum essentially brings together all 5 or 6 committee chairs of the board committees. We meet on a quarterly basis, and we essentially look for themes and learning and reflections across all committees. We've been talking about things like the committee work programmes. We've been discussing the integration of primary care aspects across all committees. We've been considering how we further integrate learning and reflection, which was a key theme from those committee effectiveness surveys that we did last year, and some other bits. But they're the sort of main themes that are coming. So it's very much the topics that impact not necessarily all, but one or more committees where we can share and kind of reflect. The other key thing that we took some action on last time was integrating feedback mechanisms at the end of each committee meeting as well, and they're slowly just being implemented as we move into the next cycle. But Carl, please do add anything if I've missed anything.
No, well, the only thing I wouldn't, not so much an addition, but perhaps just to support particularly the point around primary care, Helen. You know, colleagues will know that a recommendation that came out of our structured assessment was that we should look at the strengthening of the sightedness of the board on primary care. And so what that chairs forum has been able to do, it's been able to say, right, well, what perspective does the PECS committee, which is different to the Delivery and Performance Committee, for example, or indeed Workforce and Culture Committee, what aspect of primary care falls within the remit and the interest of that committee, so that we don't duplicate, but actually working in a coordinated way, each committee brings to bear its own scrutiny, in this case on primary care. So that's just one example. Jen, would you like to come back, or?
I just want to say thank you. First of all, thanks to all the committee chairs for the huge amount of work that they are doing, and I can see that how all of that work contributes to the overall work of the board, and I think that's great. And I'm also really delighted to see that there's some really important work coming out from that joint work that's going on right across the committee chairs. So just want to say thank you, and look forward to hearing more about that as that work continues. Diolch yn fawr.
Okay, thank you, Jen. And so if there isn't anything else in relation to the committee reports, as I mentioned earlier, no colleague has indicated that they want to remove or raise an item from the consent agenda part of our business to the substantive agenda. And if no one takes the opportunity now, then I'll assume that remains the case. In which case we move to item 3.1 on our agenda and to the Major Incident and Emergency Response Plan and our Corporate Business Community Plan. And Mererid Bowley, Mez, will introduce this. Thank you. Who's our Executive Director of Public Health, I should say. Thank you, Mez.
Diolch, Cadeirydd. Bore da. So I have a series of papers today at board and also a paper in committee session as well relating to civil contingency and emergency planning arrangements. So the first set in relation to this item is the Health Board's Major Incident and Emergency Response Plan and the Health Board's Corporate Business Continuity Plan for consideration of approval by committee members. So the Health Board is a Category 1 responder under the Civil Contingency Act, and as a Category 1 responder, the Health Board is required to undertake risk assessments, produce emergency plans, and have in place business continuity management arrangements. So the Major Incident and Emergency Response Plan and the Corporate Business Continuity Plan have both been reviewed and updated to incorporate changes which have occurred at local and national levels, and as part of our continuous cycle of reviewing, learning from exercises and keeping these documents and arrangements up to date. So during the last 12 months, as a health board, we've participated in All Wales NHS exercise, and the Powys Health Board Major Incident and Emergency Response Plan was tested as part of this exercise, which was a mass casualty exercise. And as part of that exercise, we set up our strategic and tactical response and participated in the RRF Strategic Coordination Group, as well as the NHS Wales response arrangements, which were set up as part of the exercise. So learning from the exercise feeds into our local plan, but also feeds into partner plans as well as a whole systems response. And that includes refining areas such as our action cards in our response plans. And then the second plan, the Corporate Business Continuity Plan, it's a tongue twister, isn't it, has also been reviewed and updated. And these have been minor because this report came last year as well. But it's important to note that both plans do align. And over the last year, the Health Board has responded to a number of disruptive events, including the industrial actions. During these events, we didn't need to formally activate our business continuity plans, and these were managed within our service arrangements. I'm conscious that I've also got the annual report as the next item, but I just want to draw members' sort of attention to that the business continuity arrangements at corporate level were subject to recent audit, and the audit looked at whether we had appropriate arrangements in place to ensure effective business continuity at a corporate level. And it looked at 4 areas in relation to management of systems and support available, whether relevant staff are aware of plans and the actions required during an incident, looked at communications and command structure, and then process in place in terms of testing of plans. And the audit received substantial assurance. So just thought it's important that members are aware of that in context of considering the plan. So shall I hand back to you, Chair, now for consideration of approval of both these plans before I go on to the annual report? Thank you.
Thank you, Mez. Diolch yn fawr. So once again, I will pause and invite comments, questions, contributions in relation to these 2 papers. Would anyone like to come in? Chris, please.
Yes, thank you, Chair. Councillor Chris Walsh, independent member with the local authority. I was interested to see that we built in with the major incident policy an e-learning module. I just wanted to get a little bit more understanding about that, if that's feasible. You also mentioned on the report, I think it's on page 72, that you're planning to do some walk-throughs. Is that the same of doing a live event or a live session, or is that different? And have we shared this with our local authority colleagues? Because obviously with any major incident, it's bound to obviously flow over, and just to see whether they've had a copy or will be having a copy of this updated policy, which looks very comprehensive. Thank you.
Thank you, Chris. Meredith, just before you answer that, because I had a related thought. So in terms of the e-learning module, there's an encouragement for staff to take that up. I just wondered, given the critical importance of this, is encouragement adequate? So just building on Chris's question, please.
Okay, thank you, Chris. And do come back to me if I don't cover all your areas. So in terms of training, in the next report, we talk about training where we have internal training as part of the LRF, and national training, as well as obviously exercise. In terms of the e-learning package, it is a new package for NHS, which is on ESR, and it's designed to be an introduction overview of emergency response arrangements to raise awareness across all staff. It is not statutory or mandatory. It is an introduction. So during the plan, in our training plan over the next 12 months, we aim to raise awareness of this through the corporate divisions to encourage staff to complete. There will be a different level of training in relation to staff who participate in on-call arrangements for the health board. It's mandatory for those staff to have training before participation in the on-call rota, and equally in terms of gold training and silver training as well, which we participate in those as part of the LRF arrangements element there. Does that help in terms of answering the question relating to ESR training?
Yeah. Okay.
Okay. And then in terms of the plans and sharing the plans, yes, our plans are shared through the LRF system with partners. So that would be obviously local authority as part of those arrangements, but equally all category 1 responders would have access to our plans as well.
Thank you. Chris, would you like to come back, or
yeah,
you
I mean, it was. I'm pleased to see that they will be shared, because then obviously policies within the local authority may need to be adapted accordingly to ensure that continuity. In relation to the walkthrough, which you said had stopped prior to following COVID, is that the same as then the live testing that you're going to be mentioning that could be coming about in 2024-25, or is that something different?
Different, yeah. So there's different parts of testing. So we do desktop DEX exercises as well as walkthrough of our plans exercises, and then we are due to have a live exercise this year. I think in the documentation we have to do one every 3 years. We obviously were in the pandemic response element really, which was step down 2023, isn't it really? So we are within the 3-year period there, but we are mindful that we do need to do another live exercise over the next 12 months. And there'd be different elements of the plans we also do in terms of desktop. And what we'd like to do is looking at our plans across the health board and business continuity plans to desktop exercise those with services over the next 12 months.
And we'll go now to Ronnie, please.
Thank you, Chair. Mez, I'm conscious when I raise these questions that the CAA is now 20 years old, which seems extraordinary, really, because I very well remember its introduction. But as I think you know, I come to this from a background of infectious disease, CPRNE, and environmental incidents. And against that background, I take assurance from the fact that there's good coordination between the Health Board and Powys County Council and the ambulance service in Wales and so on. But I'd just like to be clear about the arrangements in relation to our adjacent English authorities, because the Welsh Government will sign off documentation for Wales and for the adjacent Welsh authorities which are around you, and in fact for the totality of Wales. But I just wanted to be sure that the Home Office arrangements sat very much in parallel with that, and particularly in relation to the live exercise dimension that you mentioned, which is coming next year. Is that pan-Powys and wider, or purely in relation to Powys? Thank you.
Okay, thank you. Yeah, so the live exercise that we need to do a live exercise as a health board. If there is a national Wales live exercise, we will participate in that. I'm looking at the chief exec just to confirm that we will. We normally do, and we will. If there is no one in the planning, then we are planning to do our own live exercise as well. So to do those arrangements. In terms of the local live exercise, I don't see any reason why we wouldn't actually involve emergency planners in terms of our border counties in any exercise, you know, that we undertake. It all depends also on the nature of the exercise and who need to participate, but we'll also link into the LRF arrangements there. In terms of how national works, we obviously had an exercise Penydarren last October, and the civil contingency arrangements would have been linked through with Welsh Government and across the border as part of that, rather than through local arrangements. But I'm conscious in terms of business continuity plans and the industrial actions in relation to the strikes for you know, sort of doctors, etc. I know colleagues were liaising closely with colleagues in services in Hereford and Telford regarding services there, because obviously sometimes strikes are in England when they're not in Wales, and Wales when they're not in England as well. So I don't know whether Steve, a colleague, would like to come in on that.
Yes, thank you, Mez, and good morning, everyone. Yeah, so as Mez says, I'm Steve Powell, Director of Planning and Performance Commission at the Health Board. So as Mez has referenced, we do spend a lot of time with those organisations that are signalling strike action. Particularly, there's been a higher rate of strike action in England than in Wales in the past 12 months, and so the sort of work goes into both planning for that event, but also the repercussions and time to recovery after the strikes have finished, and we work on a multidisciplinary team approach to that exercise and that planning, and we've done that on numerous occasions, as Mez has referred to. Thank you.
Thank you, Steve. And I can see that Hayley would like to come in. So, Hayley, I presume it's on this point, in which case I'll come to you before I invite Jen to come in.
Yeah,
Is it on this point?
Happy to, yeah. Just two comments really. Some of the national exercises, Ronnie does look at that cross-border support as well, but I think it's an important point to draw out, and perhaps we need to bring that focus into future reports to describe how we're testing that cross-border element more explicitly. So it's a really helpful comment. The other comment I wanted to make, Carl, was around the training not being mandatory. I think there is a question for me about the process. There's a lot in the statutory and mandatory training space currently, and my reflection on that will be a helpful conversation for us to draw together on a national basis, because there's increasingly modules coming through that aren't in that space, and I think that overall prioritisation will be helpful for us to reflect on in terms of the national status of some of these training programmes. So I'll pick that up as an action with Sarah, Deb and others to make sure that we consider that in the context of this particular module. But I just wanted to reassure you in terms of the induction for new staff, but also the awareness raising. I know that the team are doing a lot of work to raise the awareness of that information being available to all staff, but it's an important point I think that we need to reflect on. Thanks.
Thank you, Hayley. Ronnie, are you content, or would you like to come back on anything?
Thank you. I'm reassured by that, Carl. I do think, Hayley, as you correctly referenced, the cross-border cooperation with adjacent English authorities is particularly important. So I'm grateful for your suggestion that perhaps there will be some additional work around that as an issue. Thank you.
Thank you. So we go to Jen. Thanks, Jen.
Mez, thank you very much for all your work on this, the work of you and your team. You mentioned the audit, and the audit seemed to go well, did go well as you presented, so that's good news. Could you just tell me who did the audit? Was that an internal audit or was it an external audit?
Hi, it's the NHS, I'm trying to think what they're called, the NHS Wales Audit and Assurance Services, who undertake the internal audits for the Health Board.
Okay, and do you know if they would also be doing similar audits to those partner organisations with whom we link up with regards to this plan?
I'm not sure, but I'm looking at Hayley. Can I bring Hayley in? Who you are?
Yes, I'm not sure it was specifically addressed as a theme this year, but definitely it's one of the key areas that internal audit would be testing across all health boards on a cycle of audit. So I'm not sure if they've all been done this year, Jen, but they will be on a rolling programme.
Okay, thank you.
Thank you. Sorry, I may have misunderstood you. In terms of that audit, Hayley and Mez, given the essential nature of partnership, cooperation, collaboration across the whole system with these matters, how do we guard against a siloed approach to audit? Helen, you'd like to come in?
Yeah, happy to, Carl. Hayley, sorry, did you want to come in?
No, you go first. I'll go second. Sorry, Helen. I was trying to unmute myself again.
No problem. And Hayley and Mez, please do add as well. So from an audit perspective, what our internal auditors will be looking at is our localised health board systems, our plans and response to what effectively are largely national guidelines. And Mez and the team will have oversight of that. They will occasionally do some thematic reviews as well, Carl, across Wales, and that will report on an all Wales basis where it's appropriate to do so. But there is a key role for Public Health Wales, I think, and the NHS executive, and that's part of the paper that Mez will present later in the in-committee session, that also looks at what those national standards and guidelines are against the Civil Contingencies Act, but also the operational workings. So I don't think there is a risk of siloed working, because they're essentially auditing against both our policy but also national standards.
Thank you. Anything to add, Hayley?
Yeah, just building on that, the sharing of information, Carl, is the key issue around this. And actually, we're working within the Powys area and in a regional space around this work, so that active sharing does take place. But clearly, there will be a number of separate orders, but it's about the overall capturing of all of that, so that we can give assurance that all our plans are taking into account any recommendations that take place locally, regionally, or nationally. And I mentioned earlier about, for example, the UK COVID inquiry module 1 report. That's again another aspect we'll be looking again in year. So it's a continuous process, Carl, of updating as new reports and recommendations come out across the whole system, and those arrangements are updated as we go along in year.
Thank you. And so thank you to the Director of Public Health, to Mez, for the reports. We are asked to approve the Major Incident and Emergency Response Plan and to approve the Health Board's Corporate Business Continuity Plan. Would you please indicate, colleagues, if you don't support those recommendations? Nobody is indicating, so those are supported unanimously. And we invite Mez now to come back in and to speak to the Civil Contingencies Annual Report. Thank you, Mez.
Okay, diolch, thank you. So this annual report documents the activity that emergency planning team, when I'm talking about emergency planning team, it's Donna Bale, who's absolutely superb element really, but she works across the health board because emergency planning is everybody's response element there as well. So it is a report that's been coming annually to the committee, and it documents the activity undertaken during the last year in relation to planning, preparedness and response. I am mindful that we might have discussed element of this report in the previous item, and they do cross over, don't they? So in terms of areas, obviously we've just considered the Major Incident and Business Continuity Plan. The report details other plans that have been reviewed over the last year, which includes the Severe Weather Plan, and also we have revised our pandemic plan as well and updated that to be a current working document, which will take on any learning as they come out of the COVID inquiry going forward, and as planning arrangements and scenarios and assumptions are released by UK and Welsh Government. But we did feel it was important that our framework was updated with the internal learning that sort of we learned really from our COVID response element there. There's also a section on training, and as I referred to earlier, we participate in the LRF Gold training, which is annual training. That we have 3 places on that sort of training, and we do have had 27 staff participated in that training over the last 3 years, and then a list of other training or exercises that are going on. An important area that we're also reviewing is logist training, and Public Health Wales are taking a lead there in revising the logist sort of training and producing log books as well that all health boards across Wales are able to adopt as sort of standard. And then I've mentioned sort of one exercise in my previous report, but within this report you will see other exercises and desktop exercise we participated in, and that includes a test or an exercise of the outbreak control plan for Wales, which is the communicable disease plan, which has been updated under the leadership of the CMO during the last 12 months. And in March, we participated in that. It was an all Wales exercise, and I'm pleased to say that the local authority and the health board were working out of the council offices in Llandrindod, Wales, for the afternoon of that exercise. Public Health Wales and Welsh Water and other partners actively participated in that plan as well. Within the report, we've included reference to the LRF structure as well, which partly also covers how we link in with partners to respond, both to respond and in our preparedness as well. And then during the next 12 months, we plan on increasing and delivering our training programme across the health board and arranging the sort of live exercise as currently referenced. happy to take any questions. I should at this point mention that within the in-committee section of the board today, there is a detailed self-assessment report of emergency planning arrangements, preparedness and resilience, which will be submitted to the NHS exec, and all Health Board and Trust have been asked to complete this and submit. And the NHS exec is also setting up a new group for Health Board exec leads in September to come together as part of a strengthened emergency planning arrangements within NHS exec. Diolch.
Diolch Myryd. I can see that Simon wants to contribute. Please, Simon.
Thank you, Chair. Thank you for a really helpful report. I'm not sure if this question may have already been dealt with in the previous item before I arrived, or just as I was arriving, so apologies if it hasn't. Do tell me to go away, catch up if it has. It was around the staff training. I just wondered if we had any data around the numbers who've done the introduction to emergencies training, what proportion of total staff that may represent. And also it may be helpful to understand how many, the kind of reach of the exercises in terms of how many staff are involved in them, how far into the organisation is it reaching, just in terms of putting some sort of scale measures in terms of some of what's reported here. So I don't know if that was already covered. I did come in, Hayley, as you were talking about mandatory training considerations, so it might have. So do refer me back if that's the case.
That's fine, Simon. You know, perhaps I just I know you did indicate that because of another commitment, you will be joining us late. So it's good to see you and very warm welcome. Let me go to Mick now, and then I'll come back to Mez for a final response. Mick, please.
Thanks, Chair. Mick Genasi, independent member. It's just a matter of courtesy, really. I did indicate in advance of the meeting that I would like to ask some questions around this item, but I think they've all broadly been answered. So just in case you were waiting expectantly for me to ask them, they're not coming. Thank you.
Okay, thank you, Mick. So, Mez, we'll go back to you for a final contribution before moving to the recommendation.
Yeah, thank you. So thank you, Simon. We did touch a bit on, you know, e-learning. We're just saying it's not mandatory and statutory. However, Hayley is going to have a conversation in terms nationally with Debs around the wider remit of ESR sort of training. But it is good that that new training is available on, you know, ESR, because there's something about raising awareness at different levels. And within the in-committee report, I have given some figures around numbers trained for participation of gold and silver and sort of bronze. And I haven't included, apologies, the number of staff across the organisation when we participate in sort of exercise, but that's something I could look at outside of committees and bring back to yourselves outside of board if that was okay with the chair. Diolch.
That'd be great.
Yeah.
Thank you, Mez.
Thank you. So we are asked to approve the Civil Contingencies Annual Report. I haven't yet heard anyone that gives me the impression that you don't approve, but please indicate if you don't support the recommendation. So that once again is supported unanimously, and we go to Helen, our Director of Corporate Governance, for her report. Thank you, Helen.
Oh, diolch, Carl. Thank you, everybody. Just a short report from me today, just with two key points in it. One is about asking the board to ratify a chair's action that was taken back in June, and that was to approve the recommendation not to apply for core participant status of Module 8 of the UK COVID-19 Public Inquiry. So thank you to all board members that responded to that and confirm that that action was taken, Carl. The second one is to ratify your recommendations, Carl, as the chair of the board, about our board committee membership. And we've listed in the paper there the membership as it is now moving forwards. Just a couple of points there are a couple of changes. It's not significant change, but just to acknowledge, as I know you did, Carl, Ian Phillips leaves us as an independent member later in the summer. So Jen will take over as the chair of the Workforce and Culture Committee. and in agreement with both Steve Elliott and Robert, Steve will take over chairing the Audit and Risk Assurance Committee from later in the autumn as well. A couple of other changes that are just noted in the paper. We will do a further review of committee membership later in the autumn. As we always do, we'll do that collectively and under your guidance, Carl, as the chair of the board. But they're the two items for the board's ratification today. Thank you.
Thank you, Helen. Would anyone like to speak to this agenda item? No, so we are asked to approve the recommendation not to apply for core participant status for Module 8 of the COVID-19 public inquiry, and also to ratify my recommendations for the changes in relation to committee membership. Once again, please indicate if you're not content to support those recommendations. They are supported, and just before we take a short break, we turn now to the minutes of our previous meeting, initially for accuracy, and I'm going to invite Ronnie to, I see that you want to come in, Helen. Would you like to come in before Ronnie or instead of Ronnie?
I was just going to quickly acknowledge, Ronnie, thank you so much. You alerted us yesterday to a couple of inaccuracies about people's role and title, particularly in the 11th of July minutes. So just to confirm, Carl, we have amended those and they will be the published version that are added to our website for the records. Thank you, Ronnie.
Okay. Yeah, and I think the learning from that, Helen, as we have briefly discussed, is that in future we will change our practice so that a draft version of the minutes will be circulated to members before such time as the draft minutes are made public, and that will give colleagues the opportunity to feed in any, if you like, typos, inaccuracies and so on, that just need a little bit of tidying up. Before, of course, they are presented to us as draft minutes for approval. So we will make those procedural changes. But in terms of their accuracy, and given those amendments and corrections, is everyone happy to approve the minutes? Please indicate if you're not. Thank you. Those are approved. Are there any matters arising from the minutes that we haven't dealt with either on the action log or that we won't deal with elsewhere on the agenda? No, so thank you for that. So we come now to our break, and we will look as much as we can to try to deal with any technical matters that are affecting the smooth flow of our meeting today, technically anyway, during the break. But we will resume at 11:15. Thank you. Bore da, unwaith eto, a chroeso nôl ar ôl yr egwyl. So dyma ni rwan yn parhau efo busnes ein cyfarfod y bore yma, ac symudwn ni yn syth at eitem 4.1 ar ein hagenda. We turn now to item 4.1 on our agenda. Welcome back, everyone. And just before we get into the business of these assurance items, just a couple of introductory remarks about the flow of our conversation this morning. We're going to start with our financial performance report, because clearly finances are important, they're a crucial resource, and they impose certain constraints on us as an organisation. And Pete will take us through that context in a second or two. But very importantly, we are not driven totally by finance. And in our subsequent reports about temporary service changes and the performance report, and particularly, I think, around the risk register report, colleagues and people will be able to see, I hope, that we place great emphasis on the quality of our services and the safety of our services. And that's highlighted particularly in the risk appetite statement and the risk register in terms of our appetite for risk around those different and complementary and that kind of biodiversity, if you like, of statutory requirements and various other requirements that are placed on us as a health board. So some very key items for discussion now, but I will turn firstly to Pete, our Director of Finance and Deputy Chief Executive, to introduce the financial performance report for month 3. Thank you, Pete.
Well, thank you, Carl, and thank you for that introduction. Some important points made there, really the link between finance, quality, services, performance, as they're all intrinsically linked. So the finance report is included in the pack. It's in the usual format. You've got the detailed finance report and the supporting appendices, which include our monthly monitoring return, which is the document that we submit to Welsh Government on a monthly basis. As usual, I'll take you through some of the key points, highlight some key issues, and then it'd be good for the board to spend remainder of time on questions and queries and discussion around the financial position. So as a reminder to the board and to everyone that we currently have a deficit plan of 22.9 million. Again, a reminder that that plan at the moment has not been accepted or recognised by Welsh Government, so at the moment is not supported. But we continue to monitor our performance and our actions against this deficit plan. So as of month 3, we have a variance against that plan, a variance of 877,000. Clearly that is very worrying. Our deficit plan is a challenge, includes a savings target of circa 9.9 million. And to be off track against that plan at month 3 is of concern. There will need to be remedial action to get us back on track against the plan, and also to deliver the actions within our plan for that 20 to 22.9 million deficit. Those key areas of pressure that is fully included in the report include our continuing healthcare, where we've seen an increase in the number of packages. We've seen a significant cost of 1 or 2 additional patches, which are very expensive, and also ongoing pressure from the use of agency in our mental health services. And that use of agency is around both nursing and medical staff. The other point to note is that against our commissioning position, clearly roughly 50% of our spend is on commission services, those services provided by other health bodies, both in England and Wales. It's still early in the year. We're still monitoring those activity levels and forecasting based on the information we have to date. But just to note that will be subject to change as we move through the year and may be an area of some opportunity. So those areas of focus I've mentioned, just to make sure the board and everyone's aware that the continuing healthcare position is subject to a specific deep dive paper, which is going to our next delivery and performance committee. And variable pay is the other area which will be subject to a similar report and deep dive on an ongoing basis. Just to note that there's been a change in terms of our variable pay group, which looks at reducing our agency spend. I've now taken over the chairing of that group, and we're very much moving it into an action focused basis to focus on the key actions on a sort of increased accelerated pathway. Other point to note is that we now have monthly finance performance meetings. These are led by Hayley. It's Hayley and myself. We see each individual exec director. They're on a monthly basis to focus on the financial performance, key issues of escalation, delivery against the savings targets within our plan, and any other financial related issues. So just to take you through the report and a couple of points to highlight, on page 2, you have the high level summary of our spend by area. This clearly highlights the pressure areas, as I've just alluded to, in relation to pay and in relation to our continuing healthcare position. If I take you on to page 3, this gives you a clear overview of the analysis of our provider-based services. So those services that we provide ourselves in Powys. Again, you can see the pressure area is in the main in relation to pay, and the highlighted area there is in relation to our mental health services, with some pressure across the other areas. Worth noting within that position, our level of vacancies. Our vacancies are running at 20% for mental health and 13% for our community services. That obviously puts pressure on our need for alternative staff cover, and that leads into some of the pressure we see in relation to our use of bank, overtime, and then agency. If I take you on to page 8, this identifies our savings plan. As the board will be aware, we had a revised plan which moved us from 24.9 million to 22.9 million. That saw us increase our savings target from 7.9 million to 9.9 million, which is a very ambitious target for the health board. But pleasing to note that as at month 3, our number of green and amber schemes is included on that page are 7.9 million, with a balance which is still in the red of the additional 2 million that we identified. So we know the areas we're focusing on there, but at the moment those schemes are still classified as red. Other important point to note is that included on this page is the reference to the Welsh Government Value and Sustainability Board, the number of key workstream areas looking at opportunities across the whole health system for Wales, and we're making sure that our plans and our actions are aligned to that group, and obviously any opportunities identified that we crystallise to be included within our financial position. Also included in the report is the usual analysis of our risks and opportunities. But just to summarise and then open up for comments and questions, we continue to hold our forecast as per our deficit plan of 22.9 million. That forecast requires the delivery of 9.9 million pounds worth of savings, of which 7.9 million pounds are currently classified as amber and green. We currently have a variance against that plan of circa 880,000. We require all budget holders or all members of the health board to help reduce run rates where possible, help to recover across our financial plan. And to note that our plan is at this stage is still not been supported or approved, so is subject to further challenge by Welsh Government. A lot of detail in the report, a couple of key issues. Carl, happy to take any questions and comments. And apologies for my getting tongue-tied a couple of times throughout that. Thank you.
No apology needed, Pete, at all. Very fluent and very, very succinct and helpful. I can see that Steve Elliott would like to come in, who's our independent member with financial expertise. Thank you, Steve.
Thank you, Carl. You just introduced me, so I was going to say Steve Elliott, independent member for finance. Thanks, Pete, for another very helpful and concise report. As you alluded to, a concern about the level of the operational deficit. Effectively, I think it's doubled in month 3, so that is something that will need to be kept under review. It does appear that there's some actions in place in terms of your role with the agency work, and also Hayley's reviewing the financial position on a monthly basis, but we'll obviously need to keep that very much under review, and in particular I think the deep dive on agency and CHC and the Delivery Performance Committee will be relevant. Just one sort of more technical question. In terms of the cash position, you're forecasting a year-end cash shortfall of around £29 million, which is obviously quite a bit larger than the planned deficit. So if we can assume that Welsh Government will at least support the planned deficit, how is the difference, the 6 million difference, going to be managed in terms of potential risks to our overall cash position? Thank you.
Yeah, thanks, Steve. I'll comment on the cash, and then I want to just come back with a further comment around our use of agency and the CHC position. So, yeah, quite right to point that out. At the moment, that's our current forecast. We do continue to work through movement and changes in our balance sheet that will have an impact in terms of the working capital changes that will have an impact on our overall cash forecast. So we are expecting that to move over the next couple of months, but we will keep it under close scrutiny to make sure that that's all covered as far as we expect it to be by the year end.
Steve, you okay? Sorry, did I interrupt you, Pete?
No, I'm not sure we might have lost Steve, but I was just going to come back and just to reinforce that focus around the agency and the CHC position. It links back to your earlier comment, Carl. So clearly our whole focus is on the quality of the care that we provide to our population. There is a direct link between quality services being the most efficient and therefore the most financially sustainable. So there is a clear link there. That's not at odds with each other. But we do know that we're using significant levels of agency, and we do know that that doesn't contribute to the best quality of care. So just wanted to make those points.
Thank you. Steve Elliott, are you, do you want to come back on anything, or are you content?
No, that's fine. Thank you.
Okay, so we go to Kirsty. Thank you.
Thank you, Carl, and thanks to Pete and his teams in Finance Division who are working so incredibly hard to get us to the position we need to be in. I'd like to start, first of all, with continuing healthcare. This area within the Health Board has been subject to a huge amount of scrutiny and interrogation in recent months. And my understanding is, listening to colleagues, that our processes are pretty robust in the sense of the way we're carrying out assessments and how we're trying to get good value out of placements. So I'm just wondering whether in the continued focus on this, given that we have a legal responsibility, if somebody is assessed for needing to continue in healthcare, there's nothing we can do about it. And given the nature of our population, one would imagine that the demands on that budget are going to grow rather than lessen. And I'm just wondering, realistically, how much more can we contain that budget, let alone shrink it? And I'm just wondering, what further work do you think might be necessary to stabilize that position? Because I think if we could just stabilize it, that would be a success for us. And then secondly, with variable pay, I absolutely take your point, Pete, that there is a raft of evidence that the substantive staff deliver a higher quality service for patients, but there are times when the acuity of a patient may actually demand additional staff that are temporary. And notwithstanding the 20% vacancy rate at mental health, if we were to fill those vacancy rates in mental health, how much of the driver for agency staff in mental health is being driven by vacancy or sickness, and how much of that is being driven actually by the acuity of staff, where patient safety would demand that we would bring in additional resource to keep those patients safe because of the acuity of those patients. And then finally, Pete, you must be very worried that 3 months in, we're so far off where we would anticipate to be. Given that, can you talk us through the thought process that had led you to the conclusion that we do not need to amend where we would think we will be at the end of the year? So at the moment, you're saying we're holding fast to the to the figures that we agreed 3 months ago were already substantively out, what is it that leads you to believe you can give the recommendation to us as a board that we do not amend our plans accordingly and that the original figures are achievable? Thank you.
Okay, thank you, Kirsty. I think I got 4 questions in one there, so I'll try and answer them in the order they were asked, but thank you, all really key points. You make an excellent point regarding our continuing healthcare, our complex care packages position, and the detail end report shows how that's grown significantly over the last 4 or 5 years. Yes, you're right, in terms of level 1, it's checking that we've got the right processes and procedures in place to make sure those people who are eligible receive the package of care that they require. This area has been subject to an internal audit that has come back with a reasonable assurance around the processes in this area. So that is sort of step 1. I think the step 2 then is, can we provide this care in an alternative way? Can we look at ways in which we could provide this care, delivering the right level of quality and in a more financially efficient way? So those are things that we need to consider going forward. And is there more that our community teams can do to support that? So that's a comment in relation to CHC. In relation to agency and the mental health position, absolutely right. So there is clearly a pressure in relation to the vacancies, in relation to sickness, and those operational, less predictable type scenarios where we need or higher acuity or higher need of patients will always be in play, and we'll need at times additional staff. I think also what we are doing is looking at, can we predict and can we mitigate that in any way? Can we look at organising our staff in that we have in a slightly different way to help manage that? So it needs a longer term solution. In terms of the position and forecast, so this is clearly the board's position. So our plan is our plan. It's the forecast that we're currently not changing in relation to the year end. Given that we're at month 3, given that there's a number of variables in our risks and opportunities which have not yet crystallised, that may give us some benefit, one of those being our commission services position, is still within the parameters whereby we can hold that forecast, noting the remedial action needed. If it continues to move in that direction, the board, because there's a board decision around that forecast, we need to consider further. I think that's covered it, Kirsty. Have I missed anything?
No, you haven't missed anything.
Perfect.
Thank you, Pete.
And I can see that other executive colleagues are indicating to come in. So if it's on this point, before I go to Robert, then please do. So let me just check in with Hayley first of all.
Yeah, just to add, Carl, about the point around the not amending our plan in light of our month 3 position with the 877 million overspend. I mean, clearly at the start, Pete indicated we had resubmitted our plan to Welsh Government in May. We're still awaiting a formal correspondence with regard to that plan, but it clearly is some distance, a substantial distance away from our target control. So I think the focus of us as an executive team has got to be, and as a board, on how do we recover and take remedial action to deliver the current plan that we've submitted, recognising that we could face a scenario where additional requirements might be set for the whole of NHS Wales. And clearly, once we receive our accountability conditions and that feedback, we'll be in a better position to advise the board on any additional actions that we need to take. So for me, it's the remedial actions that we're taking now to recover the position, recognising Steve's point about the increase between month 2 and month 3. And that will need to be our focus as a board, to make sure that we've got alternative options to consider to recover the current plan position whilst we await the formal assessment from Welsh Government from our revised plan that we submitted in May. Thanks.
Thank you, Hayley. So again, assuming that it's on this point, I'm going to go to Kate and then Steve. So thank you, Kate.
Thank you. Yeah, it was just on the just another comment on the CHC. In that, sorry, there is an element here of prevention. In that, at the moment, we know that we've got patients spending an awful long time in our beds, and in DGHs unable to access our beds because we're full, who are deconditioning and who are therefore needing CHC that wouldn't otherwise if our system was working properly. So I think so that's, as we'll come on to, we are frankly causing harm to patients by removing their independence or not giving them the full opportunity to regain their independence. And so there is an opportunity to reduce CHC by being more proactive, getting the flow in our system and getting our patients up and independent much more quickly than we currently are. So I think that's really important.
And Steve Powell.
Yes, thank you. It was just to provide some additional commentary on the Commission, and Peter, as Pete outlined. I mean, we've budgeted for growth in that commissioning forecast for the current financial year, and that is estimated to be expenditure of about 172 million. We know a number of providers are currently behind their delivery plans in terms of the providers that we commission with, but we haven't had the full contract monitoring data through as yet to fully cash up the position. So it might provide some flexibility, but nowhere near the amount that we're referring to in order to manage the overall financial position of the Health Board. Thank you.
Thanks, Steve. Kirsty, do you want to come back on anything?
No, thank you, Carl. That's very comprehensive answers. I'm grateful. Thank you.
So we'll go to Robert, and we'll go finally to Robert in terms of this agenda item before moving then to the recommendation. But thank you, Robert.
Thanks, Pete, for a very clear presentation. I'd just like to focus on the delayed discharges as a result of the non-availability of social care packages and so on. It's looking to me as if by end of year this will be costed at about 5 million, which I think was roughly the cost last year. We will expect, of course, over time for the demand for such packages to go up. So I just wondered, can we be assured of the robustness of the representations that have been made, to shift these figures? Thank you.
Yes, thanks, Robert.
Yeah, sorry, is that you, Pete? Sorry, I wonder whether you'd want to invite another colleague to come in, but over to you. Thank you.
Yeah, I was. Thank you, Chair. Thank you, Robert. I was going to just comment, and then others may want to come in. So, Robert, thank you. It's a really important point to make. We know that there's a pressure within the system in relation to that availability of packages of care and domiciliary and social care. That does have a financial consequence for us. That figure is included in our report, and it is forecast to be circa the 5 million that Robert just alluded to. We're also making sure we fully understand the impact of delays in terms of assessments taking place for individuals, because those delays also add to that number of days that people spend in a hospital bed when their care could be provided in a better and more appropriate setting. That will all be included in our reports going forward, so that we understand the pressures on the system, and that solution has to be a collaborative solution, working with ourselves, local authority, and also the support we get from our colleagues in the third sector. Just to say, I give assurance that it is high on our agenda in all of our joint executive team meetings with local authority colleagues, and in a number of we've got an unscheduled care board which looks at the flow of our patients, and it's high on the agenda with colleagues involved. But I'm sure Steve may want to add something further to that, so thank you.
Yeah, thanks, Pete. And Robert, just to give you some context of what goes on a daily basis. So all delays are discussed on a daily basis between either acute trusts and our own services if patients are delayed out of county, or within county. Active conversations on a daily basis between health and social care about the delays in Powys. So that goes on daily. Twice a week we come together as a system in a meeting called Delivery Coordination Group, where the sole focus of that meeting is to talk about delays in the system. And then it's a regular item, both in terms of our joint leadership team with Powys County Council in particular, but also, as you would expect, an enormous amount of additional reporting and actions required by Welsh Government in order to improve both flow and the reduction in the number of delays we're experiencing. But it's an extreme challenge, as Pete and everyone has commented upon. But that's the process that we work through on a sort of daily and frequent basis. Thank you.
Robert, final word, if you'd like one.
No, thank you, and I am assured. Thank you.
Okay, thank you very much. The recommendation is that we receive the financial report. We take assurance that we as an organisation have effective financial monitoring and reporting mechanisms in place, and we are asked to consider and discuss the financial forecast for 24-25, including, of course, the underlying deficit. So please indicate if you don't support that two-part recommendation. So that's supported, notwithstanding the very, very difficult and very, to use the jargon, challenging issues that that report has highlighted. And in that vein, in many ways, we go on to item 4.2 on our agenda, which focuses our attention on the annual delivery plan and the temporary service changes. And just before I invite Hayley to introduce this item, just to reiterate my comments at the start of our meeting. We met in committee as a board back in May. We looked in detail, and it was something that had been under consideration for some time as well, but we looked in detail at the temporary service change proposals. As a board, we agreed those proposals, and we mandated our chief executive and our executive team to implement the implications, if you like, of those proposals. And so the item today is about receiving assurance in relation to that implementation and its progress and its effectiveness. Of course, as I said earlier, an important part of that is the engagement exercise that surrounds that. I know that we have already received one or two items of correspondence that have either come to me individually as chair or come in elsewhere through the system, and certainly thank you for that. Those are welcome, and we will respond to those in due course. With those introductory comments, can I hand over to Hayley, please?
Yeah, thank you, Carl. In relation to this item, it's really important the context. We've just dealt with the financial position of the Health Board, but the broader context of the plan that we submitted to Welsh Government, which draws together our service, workforce and financial requirements, is still under consideration by Welsh Government. And the revised plan that we submitted in May is setting out a very challenging position for us to deliver, both in relation to service, finance and performance requirements. So in that plan, we clearly set out the need for substantial change to help us to work through towards a more sustainable position for both our services in relation to quality, value and the finance implications of that. And clearly our current system is under substantial pressure. We've just reflected on the issues around patient flow, and the position that we're facing daily in managing increasing demands on our services, recognising with our population need increasing and 28% of the Powys population being over 65 in the latest census, the increasing health and social care needs that we're working within that context is something to consider. So in relation to, if I go on to the next slide, if that's okay, please. We have set out, as Carl said, we've been working up some detail regarding the temporary changes that we may be able to put in place as a work programme to improve quality and value in year. And there are two areas that to date we have scoped that we would like to take forward for wider staff and public engagement, and they relate to the way in which we organise our minor injury units and some of our inpatient wards. We are also looking at, these are two today that we're considering, but there's ongoing work being undertaken to look at further opportunities, and we'll keep you abreast of those as those develop further, and we'll ensure again that that follows the process of staff engagement and communication as we go through that process as well. So if it's okay, Kate Wright, our medical director, is going to give you a bit of the detail of the two changes that we're considering first, and then I'll cover process and next steps afterwards. Thank you, Kate.
Thank you, Hayley, and hello again, everybody. So the two areas that working groups have looked at are of co-location of patients on the ward, which I'll come to first, and then a review of the MIU provision. So for the wards, then currently we look after cohorts of patients with mixed needs on all of our sites. We know that that isn't particularly efficient. It's expensive in that the same level of staffing is needed no matter what the patient's needs are on the ward, and it doesn't give us the outcomes that we need, as we've already discussed. So today we've got 52% of our patient population in our inpatient beds who are ready to go and have no active nursing or medical needs. We've got 10 patients waiting out of county to come back in who can't, and those patients will be deconditioning. So we need to get to a better position. And the ultimate, as we all know, our ultimate game is to get people home and independent as often as we can. Another driver for this, we've already discussed in the previous presentation and discussion about the level of agency staff, and I think Pete has well summarised, but I think it's fair to say that the level of agency use, both across mental health and the general beds, has become increasingly worrying, in that there's no issue with the clinical standards of the individual staff, but we know that when we reach a certain level of percentage agency use, then the clinical standards start to fall. The basic governance of the ward starts to become less easy to maintain, and we see our quality and standards start to fall. And that is now getting to a concerning position. So we need to do something different. So work has been underway. We've looked at evidence, or the working group has looked at evidence from elsewhere and has come to a couple of conclusions. And the plan has concluded that cohorting of patients, which happens in other health boards, would actually help with clinical safety and efficiency. So the two plans that are proposed are that our patients who need a very active rehab offer, such as patients who've had a stroke or patients who need very active rehab after an acute deconditioning in secondary care, for example, are cohorted to be looked after on two wards. And those wards would be Newtown and Brecon. And that's not to say there won't be rehab on the other wards. Of course there will be, that's really important. But what we've got currently is those patients spread fairly widely, and our very expert staff spread too thinly, so that we're not able to deliver the important rehab as well as we should be. So that is the first proposed change. The second proposed change is we've discussed that we've got a significant number of our patients who have no active medical need. Learning from changes in other health boards, then there is evidence to suggest that by cohorting those patients onto a ready-to-go unit, then there is much more efficient use of staffing, much more efficient and closer working with social services. Some of those delays that we've discussed of weeks to assessment start to reduce, and there's evidence from other health boards that by doing that, then it dramatically increases the rate of discharge and the chances of getting people home. So the proposal is that we, on a temporary basis, change two of our wards to ready to go areas, and they are Llandudloes and Broncleys. So what's really important, it's we are different to other health boards. We have seen that this has worked elsewhere. Our geography obviously is different, and it's going to be really important that we do very carefully evaluate. There will obviously be potentially more travel for some patients, but the really important factor there is that undoubtedly the outcomes will be better. There will need to be mitigation, and there will be mitigation in terms of flexibility around visiting, and we'll need to engage very closely with staff, patients and families as well. But we'll be doing that and reviewing it very carefully as we go to make sure this is the right model. And move on to the minor injuries units. Then the working group has looked at a lot of data in detail. We know that currently we have different provision in each of our 4 MIUs. So 2 are open during the daytime, 1 in Llandudno is open till midnight, and Brecon is open overnight. We know that the 2 that have out of hours provision, so Llandudno and Brecon, are seeing between 1 and 2 patients a night at present, which is not good use of clinical time and not particularly good for patients. We know that at the moment, as emergency departments are also doing, then we're asking patients to phone first. We do see people who self-present, but patients are being asked to telephone. That allows us to carry out a triage to make sure the patient gets to the right place at the right time. We know that from the work that we've done that the few numbers of patients that we are seeing overnight could very safely be seen the next day. Many patients need to come back the next day anyway for an X-ray. So we think that that's the other issue, is that currently, because of staffing difficulties, we're having to close the overnight provision in our MIU at ad hoc at very short notice, and having to put out alerts on social media, which is not to anybody's benefit. That's happened 50 times over the past 5 months. So we believe that by having a reliable and predictable service, it will allow us to bring our staff together in a more reliable way to deliver a more reliable and reliable service. Just to note as well that we estimate that the cost of seeing a patient during the daytime is between £60 and £80. Overnight, it's £300. So there's a significant financial benefit to not providing the overnight service for those 1 to 2 patients. As another part of this work, we've looked at the overall provision, we've looked at the activity, the working group have looked at it very, very closely. It's also been noted that in some of our units, the activity is low, and that having done some benchmarking with other health boards, then we do appear to have over provision of staffing in some of our units. So this work has also allowed us to look at that more closely. There's been work looking at activity in the units when there are staffing shortages and when we have very adequate provision of staffing, and we know that the activity levels are not changing. So we believe there are some opportunities to become more efficient about the way we are staffing our wards during the daytime as well. So the conclusion of that work has been that there should be a temporary service change, so that the provision for Welsh Pool and for Ustra Gunlice would not change their hours, but for Brecon that will be changed from 8 AM to 8 PM, and for Llandudno that will change from 7 o'clock to midnight to now be 8 till 8 o'clock. I think that's the conclusion of those working groups. So I'll hand back to you, Hayley, if that's okay.
Yeah, thank you, Kate. And can I just reassure colleagues, in the slides, there is no additional information in the slides that's not already in the circulated paper. We've had some issues with being able to share the slide set as we've been speaking today. So I just want to reassure there's nothing new in this information. It's just a summary of the information contained within the report. I'd also wondered, Paul Buss, our Director of Clinical Strategy, has been chairing our group, our programme board overseeing this work. Paul, I wondered whether you wanted to add anything further to what Kate has just referenced before I take the board through the next steps.
Well, thank you, Hayley. I'll be very brief, in fact, because I think Kate said everything by and large that needed to be said. There were one or two things. I think the concept of the deconditioning syndrome has become increasingly important in the last decade. It really is real. You can see it with your older loved ones when they're in hospital. From the very first day they've got bed rest, they start to decompensate. And so maintaining the physical, psychological, and functional capacity of people is vital to getting them home independently with a lower level of package of care. And so increasingly, I think that it's a must-do that we go into the kind of ready-to-go units. The other thing is that the discussion earlier on about flow, well, I think this could be a game changer for us. And so it's really important, I think, that we start to grasp these changes in the model at the systems level and evaluate the expected changes in the positive direction, and they could be very serious improvements for us. So that's the co-location. In regards to the MIUs, what I'd say is that the adjustment in hours would be consistent with all the units that you'll see in rural health boards right across England, Wales, and Scotland. The kind of hours of adjustment are minor changes when you think of the activity that takes place. And so, yeah, the board that I chaired fully supported the evidence base and the clinical rationale for going forward with these cases.
Thank you, Paul. So in relation to next steps, before I take you through the timetable, it's clear we've talked about the very immediate challenges that the Health Board faces, and that these need very immediate responses, which we've just taken you through, which are the temporary changes we're putting in place. But I also wanted to confirm, therefore, that the staff engagement has started, but we need to continue to do that during the period of time where we've set the public and stakeholder engagement over the next month. And the next slide, I'll cover that. Also, the plan around this is to move rapidly after that period to implementation operationally, and then to continue to work on other ideas that the board will want to consider in the space of some interim changes as we move forward with the very, very important work that we've started to do, which is through our Better Together model. And that's about making sure that we can develop a health system that's safe and sustainable for the future. So this does mean that the changes we are making in the temporary interim space this summer are not necessarily the final permanent future model we would want to put in place, and that we need to take the time to allow ourselves the opportunity to continue to work, learn from these temporary changes, but also, more importantly, to work with our frontline staff, our communities and partner organisations to agree the permanent future model. So that work will continue in the autumn, which is around how we take forward that work in partnership and in the public space. And I know, Carl, you'll be asking a little while for Llais view around this, who've been helpfully observing the programme board arrangements that we've had in place. So in relation to the next slide, if that's okay, on staff engagement, clearly we have an ongoing requirement to continue to discuss with all staff about the proposed changes, but also our partners in primary care, third sector and social care colleagues, and we expect these temporary changes to be in place initially for 6 months, with that checking that the outcomes we're anticipating that will be delivered do get delivered, and that we've got a strong arrangement which the team are working on to evaluate the changes. And then later we'll be making sure that we engage in that final long-term model across both staff, partners and other organisations. So just some examples of the staff engagement. Obviously we've had staff side input in the programme board arrangements, but there's very live discussions taking place currently with staff who are directly affected. And only earlier this week we conducted a staff briefing session, but clearly there's a lot more for us to continue to do to have the right dialogue with both our staff and as well the public. On the next slide then, we set out clearly that we will be embarking on a period of public engagement from next week, the 29th of July, to raise awareness of our proposed changes, the reasons for the change and the potential impact on patients and communities, but also to seek feedback. And again, we've been working with Llais on this very matter, so all of the materials associated with that will be going live next week on all of our communication channels. So that was really a summary, Carl, of the paper. Hope it's been helpful. There's a lot to take in this paper, so I thought it was really important for us to go through each of the points step by step. So very happy to answer any questions you may have.
Carl, you're just on mute.
Apologies. No, I was just saying a thank you to Hayley and to exec colleagues for what certainly I thought was a very succinct, clear and comprehensible presentation of tricky information, and so thank you for that. So as you said, Hayley, I would like to invite Katie from Llais in Powys. Katie's our regional director for Llais, the citizen voice body. The voice of patients, the voice of people is absolutely crucial in these processes. And Llais, as Hayley said, has been part of the discussions and the process to date. So just invite your perspective, please, Katie.
Thank you, Carl. Yes, I mean, I think before I start, I must just remind board members that we are independent and that this is a decision for you as a board. And that sort of difference is really, really important, because we may further down the line decide to challenge a decision that's taken. Hope not, because of the continuous engagement that's going on. Yeah, I think from our point of view, we've been attending the last couple of programme board meetings as an observer with speaking rights, which I think has been very, very helpful. But just to again reiterate, we're not part of that decision-making process. I think we again are very fortunate in Powys, because we've been having discussions on an ongoing basis for quite some time. And things like Kate mentioned, the visiting hours, we sort of had picked that up as the need to review that and have an element of flexibility if patients and family and friends were going to be needing to travel a little bit further. From our perspective, we continue to work closely with your colleagues in the Health Board around the comms and engagement plan. The frequently asked questions, Adrian and I have had quite a detailed conversation about some of those. Obviously, there'll be an equality impact assessment, so just working through that and looking at any mitigations that may be needed from a patient and community perspective. I think we obviously in Llais, Powys have started, as you know, to work on an intensive community basis, and just to remind board members that the ones that we've undertaken so far are Llanidloes, Brecon, Ystrad Llais, Bilth and Ryder, and we will be visiting Machynlleth in September. So there are other opportunities both to feed in what we've heard, but also perhaps to use that as part of the continuous engagement going forward. And just finally, Carl, I suppose from a wider Llais perspective, the regional directors are meeting on a weekly basis to oversee what's going on across the whole of Wales. I feel very fortunate that we have the relationship that we do in Powys. It's a very mature relationship. We don't always agree, but we have that maturity to have those difficult conversations. And I do feel fortunate. It also provides me those weekly meetings with an opportunity to try and keep a handle on other changes that are happening in other parts of Wales, which may impact on Powys patients. So I'm happy to elaborate any further if people would find that helpful. But I think in summary, just to provide that assurance.
Thank you, Katie. I'm conscious that we are running over on time. However, I think my view is that this is such an important key matter that we need to give it the time it warrants and the time it deserves, rather than simply be straitjacketed by the timetable. And so it may mean that our meeting today lasts a little bit longer than scheduled, but I think that's an important thing to live with, as it were, for today. Also, I just want to explain that our meeting today, as all of our board meetings, are meetings that are held in public. But there's an important distinction in that they're not public meetings. And so the only people able to contribute to the discussion are board members. But there will be opportunities, as Hayley has indicated, for the engagement of people, partners, stakeholders within those processes and procedures that will underpin the decisions in relation to future changes. But I will go now. I will take the three people together. So we'll go to Robert, Kirsty and Chris in that order. Thank you, Kirsty. Sorry, thank you, Robert.
Thank you, Chair. Quick question, really. Can we be assured that these changes are compatible with our 5-year plan? So, for example, the changes to the MIUs, that will fit in with our plans to expand the MIUs, MIU Plus model, which is in our plan, and similarly the concentration of certain patients. Thank you.
Kirsty, please.
Thank you, Carl. In speaking, Kate spoke about the need to continually monitor the situation. How will we know that we have achieved the patient outcomes we believe we will achieve as a result of these changes? And what data will be available to us to pivot to different decisions if necessary? And secondly, what impact will these changes on the wards have with our relationship with GP practices in the area that have previously supported medical care in those wards? Thank you.
Thank you. So I go finally to Chris, and then I'll invite executive colleagues to come in. So thank you, Chris.
Okay, thank you. I wanted to ascertain about the discussions going on with the local authority in relation to the ready-to-go units on the, has there been already discussions going through on that? Has it been brought up with the unscheduled care board, for example, to see whether how that factors in relation to some of the potential reallocation of patients to different locations. Are any of the wards or buildings going to need to change, and is there any additional cost to that on the and you mentioned about temporary provision. Obviously I know that this is a moving beast, and we will be reviewing that on there, but is there going to be a clear timeline of when these decisions will then be reviewed so that we can obviously plan for the sustainable services that we're looking for going forward.
Thank you. I can see that Kate, you'd like to come in, so please do now, and it may be that other executive colleagues and Hayley might want to comment, but Kate.
Yeah, thank you. In terms of the 5-year plan and whether these plans are compatible, Robert, then I think the answer is yes, in my view. In terms of the MIUs, then the work stream has done a lot of work to look very carefully at current activity, look at and again benchmarking with other health boards' activity, and absolutely within this plan there is plenty of scope to expand what we do, and we continue to we have been continuing to train and upskill our EMPs, so that plan is continuing and our ambition remains. In terms of the cohorting, then again, we believe, as we've discussed, this is a move towards sustainability, better use of staff and efficiency with better outcomes. It's the evaluation will be really, really important. Obviously, that's stating the obvious, I know, but you know, if we hope that these plans are going to work. If they don't, then they are an evolution into our sustainable plan and will help inform whatever has to happen next. In terms of the medical care, Kirsty, I think that's a really important question. And I know we've got some GPs here. Then what happens next? I think this has been, I'll be really honest, this has been challenging because of the pre-election period. We haven't been able to have as open a dialogue with our primary care colleagues as I would have wished, but we have had dialogue as part of the Accelerated Sustainable Model over the last year, 18 months, and I've had some dialogue with primary care. What's really critical now, you know, our ambition to treat as many patients as we can as actively in Powys remains. What we want to do is to make sure we keep all the skills of our primary care colleagues who provide an excellent service, and very, very quickly now, then we need to work with them to work out for those sites that might not be providing for this temporary period the current care that they do, then we believe there may be really important alternative models. I think going back to the agency issue, then you know, we have ambition to try and do more step-up care, more active care. I have grave concerns about doing more active care with the level of agency use we've got. So I think in order to get to a position where we can start to look after slightly higher acuity patients to meet the ambitions that we have, we need to consolidate first and then move on. And I think this is part of a consolidation to get to a position of more sustainability and safety before we build. But so I think the summary is there, then very important dialogue and constructive dialogue with primary care needs to follow very quickly now.
Thank you, Kate. So I'll invite Claire and Paul to contribute. Finally, I'll go to Hayley for some final comments and reflections, and then we'll move to the recommendation. So Claire, please.
Thank you, Chair. I was just going to come in on discussions with the local authority in response to Chris. We have been corresponding really regularly with local authority colleagues. We have a weekly operational meeting, which they are invited to attend and participate in the full operational planning of these wards. And just for further information, we also invite the third sector lead, Claire Swales from Pavo, to that meeting as well. So everybody is fully informed as we make decisions and as we discuss ways forward. So just some reassurance there.
Thank you. Paul.
Yes, I just wanted to assure you, Kirsty, that we're looking actively at the outcome measures that we want to collect in relation to this work. We're you know, some of these will be traditional activity based, you know, length of stay, etc., readmission rates, and comparisons with current. But actually, we're working actively on a group of outcome measures which are linked to the ICHOM data set for older adults. which looks essentially at things like autonomy and control, emotional well-being, activity and daily living, and we will have that data set embedded in the work that we do.
Thank you. Hayley, final reflections from yourself, please.
Yeah, no, thank you. So just building, thank you for everybody's contribution in response to those questions, just building on a couple of points. The first one is on the social care and third sector relationship. I just also wanted to share that we've been placing this discussion into the Regional Partnership Board, particularly the work around the ready to go home elements, because we know that for this to work, we need it to work across the whole system, and we rely on the support of the third sector and our social care colleagues to address some of the improvements in flow and outcomes that we're achieving. So I wanted to share that, and also we've got a briefing later this week, Chris, for the Cabinet. So as an example, so people and there are other mechanisms of engagement over the next few weeks that we've got planned as well. The relationship with primary care is really important. We rely on primary care very heavily in Powys. It is our core business, and in particular our GPs provide medical cover for all of our hospitals. So just wanted to say that we will and continue to work alongside our primary care colleagues to ensure that any temporary changes doesn't destabilise primary care further. So, I think that's a really important aspect. We'll have to work very carefully with our practices around that. I think there's a point of clarification that I'm hearing in some of the engagement, which is, what does this mean for other hospitals? What does this mean in other areas? At this point in time, the two changes as described is it. But I should say there is further work being scoped on the overall opportunities that we have available as an interim, and as well to support the longer term model of care. So these are the first of two that we're able to bring to the board for assurance today. And then I think the final point is the issue around pivoting decisions or reviewing decisions. My view on that is that the ongoing evaluation and checking of these changes, the very active sort of learning as we go along, is really, really important, and we'll be very clear on any trigger points that need to bring it back to board for a decision change with regard to any changes that come through. And clearly during the engagement period as well, there may be other insights that we'll hear from the public or from stakeholders that we will need to potentially refine and look at ways in which we mitigate perhaps some of the feedback that we'll receive with regard to these changes. So I guess it's an active piece of work, and it's about getting that reporting clearly back through to the board and committees, as well as the day-to-day operational management of the implementation of the changes. So those were my points, Carl. Thank you.
Thank you, Hayley. And just sometimes the language and the terminology we are required to use perhaps is a little bit misleading, and that's not helpful. Temporary is may not be the best word to use in this context. However, it is the word that's within legislation and the one that we're required to use. However, as you rightly say, Hayley, this is a journey, and this is part of our moving towards agreeing with partners, with people, that sustainable model that will provide safe, quality services into the future for the people of Powys. But do you want to come in again, Hayley?
Yes, apologies, Carl. I was just checking against the list of questions, and one point that Councillor Chris Walsh raised was around any additional costs associated with these changes, Chris. Not in the first instance around these two particular changes, no, but clearly that's part of the reason why the longer term we've got to look at that, because it will, in my opinion, be looking at options that will require us to change potentially and have investment in the facilities that we deliver our care within.
Thank you very much. So let's turn to the recommendations connected with this agenda item. That we received the report and we note the status of our plan and our integrated plan, but also importantly our annual delivery plan for 24-25. That we take assurance that 2 of the 3 temporary service changes have progressed as planned, namely the dedicated units for people according to clinical need, the so-called ready-to-go-home units, and the MIU opening hours. And we also note that further work is underway to identify additional schemes for future consideration, including considerations in relation to older mental health inpatient services. Would anyone like to indicate, please, that they don't support that composite recommendation? So that is supported unanimously. Thank you. So again, we gave that much more time than perhaps we'd anticipated, but I think that was the right thing to do. And thank you very, very much for the information and for the discussion. So we turn now to the IQPR, the Integrated Quality and Performance Report, and I'll ask Steve Powell to introduce this agenda item. Thank you, Steve.
Thank you, Chair. So this is the Integrated Quality and Performance Report to month 2 with all data that we've got up to the end of May. The report itself follows a similar style to previously reported. So there's a cover paper and then quite a detailed performance pack to provide that for further assurance and performance position on a whole range of targets. The cover paper itself, what I'll do, I'll comment on some of the absolute service numbers and performance of some of these our challenges, and then summarize at the end our performance against a number of trajectories that we've submitted to Welsh Government. So starting off with our own planned care performance in our own provider arm. Overall, delivery remains quite challenging, with a number of services still reporting some fragility in terms of the way they are delivered, and also some delays in terms of access to diagnostics. There is an improved position though with our therapy services in month, with all of the targets being met for under 18s, but there are 2 targets for the adult population that did report some breaches. So overall, from an referral to treatment perspective, our own provider arm, at the end of May, there was 1 patient who breached the 104-week target. No patients breached the 52-week target, where they are waiting for an outpatient appointment. So that's really positive, and we continue to perform strongly in that area. From a mental health perspective, and again, these are services provided in Powys, our performance for under 18s remains really robust, and we're passing the majority of those targets, with the exception of neurodevelopment services for children. Adult provision remains a mixed picture, to be honest, with Part 1A assessments reporting a slight increase in performance, but below where we would want it to be. And again, challenges with neurodevelopment for adults in those services as well. Kirsty mentioned it earlier, but just to flag, this report also highlights that our inpatient mental health services are currently under a higher level of escalation within the health board because of some quality issues with the inpatient services. Those are all being worked through with executive members of the team and the services themselves, including the criteria for de-escalation. From a commissioning perspective, that's where we buy services from health boards across Wales and English trusts across the border. The general position with waiting list sizes is that they are increasing overall within every health board in Wales and also in England, because the demand for those services are high. In terms of extreme long waiters, that's patients waiting more than 2 years for care, we are seeing an improved position in Wales, and the numbers are slowly coming down. So at the time of reporting, we had 187 Powys residents waiting for care in other health boards, and there were 187 of those. And in England, we have, again, at the time of writing, we had 29 patients waiting more than 104 weeks, and those are all at Robert Jones and Agnes Hunt, waiting for complex spine procedures. From a cancer care perspective, the performance against the main standard, which is the 62-day access standard, unfortunately, all those, all the providers that we commission of are not delivering that standard, partly because of an increase in demand, but also the capacity to deal with the increasing number of referrals coming through. So all targets, whether they're being not delivered in our provider arm or not delivered in our commission services providers, all attract additional attention and scrutiny, not only from those organisations themselves, but from us as a commissioner and with the different regulatory oversight, be that NHS Wales or NHS England. And page 7 of the report just summarises then our performance as a provider versus the trajectories that we set ourselves and submitted as part of our operational and business plan for 24-25 financial year. So the first table on page 7, that summarises that we are passing 6 out of 7 of the ministerial priority measures, or cabinet secretary measures as they're now referred to, and the bottom half of page 7 goes on to describe our performance against our mental health targets, where we are passing 4 out of the 5 of the trajectories that we set ourselves, and from an adult perspective, we're passing 2 out of 4 of the recovery trajectories we set ourselves. So I'll pause there, Chair, in terms of that overview, and invite comments from other board members. I may well need to bring in other exec colleagues depending on the question asked. Thank you.
Thank you, Steve. Before I invite others, colleagues will know that we have spent some time in board development sessions looking at our performance and our performance reporting, particularly a sense that nothing changes hugely between performance report and performance report. You know, it could be summarised as what we deliver ourselves is not perfect, but it's generally okay. Whatever fragility we have is partly about in reach, for which we are dependent on others. And then our performance in terms of commissioned services is generally not okay, but it's a little bit like Groundhog Day when we receive these reports at boards, and so we have been giving some thought, haven't we, and some discussion as to, you know, what is our response to that, and how might we take that forward? You know, in terms of what's in our control, what's not in our. I just wondered, Steve, whether you might want to give a flavour of the discussion and perhaps your take on the outcome of that discussion.
Yes, thank you, Carl. Yeah, so on the 11th of July, we did discuss some of these commissioning intractables, as we've referred them to, because a number of these services are not in our direct control, clearly, when we commission them from other organisations. So there are a number of indicators that are not being achieved. And as Carl said, we're trying to get behind that high level data to see if anything beneath that main indicator is changing. So, for example, the cancer 62-day standard, we can look at some of the underlying measures to see if, whilst the overall target might be not being achieved, are other indicators improving along that pathway. So things like the number of referrals being made, the time to access diagnostics, the time to which the referral is made to the secondary provider. Are those components of the pathway improving to try and help delivery of the overall target. And similarly for the A&E target, for example, that hasn't been passed for a number of years in terms of the 4-hour wait. But what experience are our patients actually getting in terms of the total duration that they wait, the time to see a clinician, the time to discharge, and the time to be admitted to a ward or not, and the time for recommended care packages, whether that be a stroke bundle, a care bundle, a sepsis bundle, and so on and so forth. So there's a lot of information behind these initial indicators to truly see whether performance is being improved or not. Now we can't bring that through every month, otherwise our performance report would sort of balloon to about 600 pages. But I think we should either through board development sessions or on a rotational basis include more detail about some of these indicators that continually fail to broaden that understanding and sort of direction of improvement. So that's what we'll start to do. Thank you.
Thank you. That's really helpful. So we go to Ronnie, Robert, and then Steve Elliott. Thank you, Ronnie.
Thank you, Carl. Steve, just a very quick comment. In relation to our commissioned services from England, given that the Secretary of State has now launched a review of NHS provision in England, do we have any feeling for that, how that might affect our commissioning figures and commissioning intentions? And I know we're very early in the process. I'm just looking for any early field intelligence. Thank you.
Thank you, Ron. Steve, we'll take Steve Elliott, Robert and Steve Elliott first, and then we'll come back to you, Steve Powell, if that's okay. Robert.
Yes, thank you. Yes, following from the comments of the chair, I'm sure we all take a deep breath when we receive these figures, Steve. A sea of red. Across the spectrum of planned care, demand is increasing. My question is about the modelling of that demand. Has modelling previously been successful in predicting the increases that we are seeing now? And if yes, is there any prediction of when demand will plateau out? Thank you.
And Steve Elliott, please.
Yeah, I'm just going to ask about data quality, because I think there are a few areas where reference has been made to concerns about data quality, and I'm just wondering whether that's an internal issue within Powys or relating to external providers of data, recognizing that there's a lot of data in obviously these reports, but just to check that we've got robust processes to ensure the highest data quality. Thanks.
Would you like to respond, Steve?
Yes, I will. So Ronnie, thanks for the question. So you're right. There has been a review requested, and there were certainly some commitments to much improve capacity within the English NHS, whether that be outpatient capacity, treatments, reduction in waiting times, and the development and further expansion of things like community diagnostic centres and surgical elective hubs. So that is all good news from a Powys perspective in terms of opening additional capacity to for patients to flow through and get treated. NHS Wales is also doing a similar thing. There's lots of work being underway to improve capacity, regional working, and regional centres of for elective care. So I think from a patient perspective and a commissioning perspective, increased capacity obviously then reduces waiting times. It can occasionally increase journey times depending on where that capacity is open, but generally we would expect if more capacity is opening up, that means patients will get treated quicker. Robert, in terms of planned care, so yes, a lot of modelling has been done, not only by either NHS Wales or NHS England into future referral demands and health, the burden of health, shall we say, but we've also done modelling internally to look at demand and capacity planning for our own commissioned services. Now that still does need some further work to fully understand that relationship between demand and capacity in all services, but we're on that journey of improvement, shall we say. In terms of when do we see demand going down? Well, actually, I don't. It's how, for some of the reasons we talked about earlier, in terms of parish being an elderly population, more surveillance, more screening. I think the demand on healthcare services will increase, but it's how we respond to those increases that is key, and that drives some of the conversation that we've heard about today in terms of future model of care for Powys and with other providers. And Steve, just in terms of data quality, whether we've got internal or external challenges, it's a bit of both, to be fair. So we have previously had some challenges with our follow-up waiting list, and we've done a big piece of work to clean up the validation in that area, and occasionally some of our external commission providers will also have some data challenges. Unfortunately, that's a bit of the nature of the beast in terms of the number of systems that are used across the NHS, and occasionally there are data quality issues. Our performance as a health board, last year we did have substantial assurance on an internal audit that was undertaken about our performance processes, so I do take some assurance from that. And also we do have very good clinical coding compliance, so that what that means is where patients are an inpatient within our beds, we translate their actual care into what's known as clinical coding for additional scrutiny and planning purposes elsewhere.
Thank you, Steve. So I can't see anyone else wanting to contribute. So I will put the recommendation to the board, and that's that we discuss and note the content of the report, which it seems that we have, and that we take assurance that the health board has appropriate systems in place to monitor performance and to respond to relevant issues. Does anyone want to not support the recommendation? So that, once again, is supported unanimously. And thank you very much, Steve, to you and your team for all the work that goes in, yes, day in, day out to monitoring stuff, but also the quality of the reports and so on that come to us, and like other reports that we have. So
thank you, James.
Appreciated. So we turn to item 4.4, and Helen is going to introduce the corporate risk register and the revised risk appetite statement. Thank you, Helen.
Thank you, Carl. So pleased to present this to you today. Board members will recall that we've been taking some time to review our corporate risks. And just a reminder that corporate risks are the high-level risks that hinder achievement of either our strategy or our integrated plan, much of which are the same thing, and they're where they cannot be managed within individual directorates or service areas. So these are risks that span the course of more than one area of the organisation. So presented to you today in Appendix 1 of the paper are those 11 revised corporate risks. That supersedes the risk register that the board last saw back at its meeting in May. So all of those have either been brought forward or made redundant in effect. So they're offered as an assurance to the board as a complete and true reflection of the high-level risks currently facing the organisation. And you will have already seen throughout the course of the meeting so far that we've already discussed inadvertently a number of the risks areas throughout our agenda. So just in summary of the 11, 3 of them relate broadly to financial sustainability, and we've heard much about that earlier on. 4 of them relate to quality, 3 are about performance and service sustainability, and 1 is linked to safety. And they cover a whole variety of topics, as you will see in the risk descriptors, everything from demand and workforce issues in primary care, cyber and power outage issues that would cause service challenges, financial management, as I said, increase in the demand for both our provided and commissioned services, as we've just been hearing about in the performance report, but also areas around